Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. Welcome to KIMEcast. Tony Mikla, Russ Dunning. The big thing with sports med, I think there's some key elements in sports medicine that allow you to be great in this field and great in this profession and really serve the population effectively. So one of the number one factors would be
principle number one, easy access, rapid access. You need to be the person to call. If the games are on the weekends, Friday night underneath the lights, you're getting the text Saturday or Sunday or Monday.
Yep, that's how it rolls. It's you got to be able to respond quickly. So I think it's a attitude of, you look forward to that responsibility that someone gives you that honor to say like, hey, my kid's injured, or if it's the athlete themselves, hey, I'm injured and I need your help. And what should I do now? What's my next step to take? The whole intention of the field is to put yourself in a position where you're that person, where you're the person who can provide a solution, provide an answer, be the provider of choice in that moment to say that, hey, maybe it's not me as far as a physical therapist. Maybe you don't need me today, but I can help guide you as to what's your best path to recovery.
Yeah. We're becoming the direct access. I think the key thing of sports medicine is quick, immediate, rapid, direct access, and you really control the journey from day one, which we know you can mitigate inflammation, you can improve healing, you can improve circulation, you can get them going on the right step. Versus both the people and the business models that are more in the disease medicine model. It's when you make that call for an appointment, you get in line. And you get in line by the 20 other people that need that person's help. So there's no really shortcut. If you've been having chronic back pain forever and now finally you made an appointment, you're in line to be seen by the physical therapist. But in the sports world, hey, the injury just happened. I need access now because I need to know what to do. Because the truth is, if you don't manage the acute phase with an injury, you're setting your timeline up to be quite delayed. So I have a case this weekend. We had a knee sprain that happened on Friday night. Is an elite level football athlete for the best team, one of the best teams in the region. And it was a mild tweak, but it was a distinct tweak. It was a knee sprain of the LCL, and it affected his ability to run. He knew he couldn't run without pain, and he knew something was wrong. And so that rapid access allowed me to then say, okay, let's diagnose it. I gave him a Varistress. I pinpointed palpation, fully flexed the knee, fully extended the knee, kind of traced back what the pain pattern was, pain with a deep squat, and all of that validated, to me, minimal chance of meniscus injury, high suspect of a mild strain of the LCL. So now what we do is we dial in nutrition, we dial in supplements, we dial in the right exercise, we dial in the right avoidance of certain exercises, the right modification of practice. I communicate with the coach. I told him these are the things that you are doing. Here are the things you are not doing. I'm going to flush out the area. I'm going to put a little cup on it to bring some blood flow into that spot. And we're going to do all these things. I'm going to see him probably 3 or 4 times this week and the next to make sure it's a very smooth progression. So that way we can take what might easily be a 6-week injury if you have a delayed start to the journey to hopefully more of a 15 to 20 day rapid journey through this recovery phase, and that way he can play in the playoffs.
Absolutely. It's funny you said that. I mean, I did exactly the same process with a different football athlete with an MCL 2 weeks ago, a college kid, and he had an MCL strain at a game. I've seen him for several years, so I've known him forever. And so, he hits me up right away. It's like, hey, this happened. I'm out. He kept playing the game, which was great. And then they had an evaluation with the docs and team docs on Monday, and that week was a bye week. And then he had one. The following week was the week to kind of go back to play. So he'd never missed a football game in his career, which I thought was interesting. It's amazing to think this kid's been playing since, he's a senior in college. So he's been playing for this, but he never missed a game. So it was really interesting. He's like, he didn't really say this to me, but talking to his dad, his dad converted with me. He's like, he's never missed a game. And I'm like, wow, that's actually amazing. Because I've rehabbed this kid a number of times. I'm like, this is kind of incredible. But then we talked about it. He's like, yeah, if I do miss a game, I'm really concerned that I lose my position, right? It's like, because there is another kid that he had to beat out in camp to keep the position, be the starting guy. Even in the beginning of the season, there was a little bit of a battle, but he clearly demonstrated that he was going to be the guy. So he's worried that if he has to sit, the other guy comes in. If he plays well, then he's off, which is very much real. It's the next story of another person that happened to, and I think it's really tough. So, anyways, same kind of ideas. He was getting good care. The team did a nice job. They ultrasounded his knee to assess what degree of MCL it was. They gave it a grade 2, grade 3, so it's pretty substantial. And then we had they then did an MRI. MRI came back a couple days later with the same result as grade 2, 3. Although he has no pain with extension, only pain with terminal flexion at the very, very end. But otherwise, he could walk with no limp, and all of that was pretty good. So we saw him, 10 days straight. We saw him 5 days 1 week, and then we gave him the weekend off, and then saw him 5 days during the bye week. He ended up being cleared to play by game time Saturday. But the problem is that's not good enough. So when you have a bye week, if you're a coach of a team, you have to have the athletes that are going to play Friday with you on Monday. Mm-hmm. So although he was able to probably go at like 80% on the Monday prior to the Saturday game, he didn't have his brace yet. So that was something we were dealing with. So I got involved with the brace rep, and I was like, hey, I know the brace guy well. So I'm like, hey, can we get this thing done? He's like, the school wants him to use other brace. I can't get that brace for like 2 days. But if we use this brace, I have it right now, ready to go. So it's like,
politics.
Yeah, so the politics get involved in some of these things, and just preference, which can be fine. But if we actually put the athlete at the center of this, and granted, obviously time is necessary for healing, and I wouldn't have wanted to push him back in an unsafe environment, but he was completely asymptomatic with everything except cutting by Sunday with 5-6 days to go. So he could have definitely put the brace on. That was without a brace. So he could definitely put the brace on and been pain-free with cutting on Monday, and had a nice workup, and then been effective. But it was good to be a part of the process and get him back out there. And he said, he suited up and stuff on Saturday, but didn't play, didn't take reps, didn't take snaps. I don't believe, because he hadn't taken snaps during the week of practice, even though he did on Thursday, Friday. It still wasn't enough to put him into a role to be a playing situation. It was in his best interest. So that was all great. But we'll see. We'll be back in the mix this week, and they've got some big ones coming up. But I think that there is some political games there, unfortunately. And one thing I will say, that when we had the athlete on week 1, he was getting treatment on campus, and then we were also doing treatment both. And I did not have the luxury of knowing the team that was doing the treatment on campus. So I could have extended more there and been helpful, but this athlete's a very, very good communicator, very, very clear on what's going on. She showed me everything they're doing. We just modified a few things, basically just doing a second treatment of the day. We didn't add more stuff, except what you said. We added the nutritional component. We added a lot of blood flow circulation component. We added a lot of things to facilitate the healing process and make sure that was good. On their end, one thing they were doing that I wasn't so thrilled about is that they were having him do plyometric work on that first week, because he was asymptomatic with at least linear and vertical work, right? Which is great. But the question for me is like, why are we doing plyometrics now? Like, what's the risk reward?
Right.
Clearly we know he was injured. Yes, he finished the game. Could he do a plyo? Sure. But he's no different on plyos on Tuesday, today, or whatever day it was, than he was on Saturday at game day. Yeah. So there's no reason to train plyometrics. Right. We're not trying to, if he had been out for 8 weeks and now we're having to bring the muscle back, then that's one thing. Right. But from a healing perspective, the thought process was, let's just rest the kid for the week. Let's do everything we can do to increase blood flow. Let's do heavy strengthening. So we increase testosterone, increase HGH, increase all the things in the blood to increase growth. Let's facilitate tissue healing. But let's not challenge that tissue in any way. Why would we challenge it? It's a bye week. There's no reason to challenge it. I think we're not in a tissue tolerance scenario.
I think it was a bit of a mistake. I think I could see the argument of, say, they were a 100-meter sprinter, and you knew that the only way they were going to be successful is if their nervous system was that razor fine-tuned. Right. And then, hey, if you're doing this said thing in 7 days, I need you to do this thing 5 days out, 3 days out, 2 days out. And it's worth the risk, because we're going to keep the volume here, we're going to keep the intensity here. So I get it if the competition of focus is like 99% neuromuscular. But for the majority of sports, that's only one component of it. The capacity, durability, stamina, conditioning are probably more important. I mean, especially in football, when you're the fastest person in the world, that doesn't mean you're great at football. You have to be insanely durable.
Yeah, absolutely.
And tolerant to cutting, and tolerant, and then not to mention the whole IQ of the game. So that's a mistake of principles. Which one way is the most important?
What's the most important? Yep. Especially midway, 7 or 8 games in, a week off at this point is not going to do anything except help the kid.
Right.
And I would argue you're right about the sprinting thing. If we had to go the same week, so if we would have had to play Saturday, then I would be supportive of it. Like, well, we're not no rest. I mean, 2 days of rest isn't going to be enough to like turn the corner, But since we had a bye week, it's like, all right, let's eat this week.
Yeah,
give the kid a recovery week. It's perfect on the progression side of things. We're 7-8 weeks into the season. It's a great time to take a deload week, get the body to recover, facilitate the healing process, still load him in a different way than he's used to. But let's not go right back to the football things that hurt him. Let's do some other stuff and stimulate the system in a different way. So that's what we shifted the attention to, and I ended up doing great, like we said. So that was awesome.
Well, I think all of this kind of paints the picture that in sports medicine you have to truly understand the sport. What are the demands of the sport? What's the seasonality of it? What's the type of game it is? What's the structure? And that helps you do modifications. Baseball athlete versus football athlete versus a tennis athlete versus volleyball. I mean, how they have to warm up their body. Is there a downturn in the middle? With football, you get halftime. Tissue can tighten up. And shoot, with football, they go back and forth between offense and defense, so you can tighten up in between sets in that way. So each sport has its nuances that they really have to understand both the pathologies critical to the sport and the sport demands to really even come close to operating in an acute, subacute phase and helping a smart return. Yeah. So you really kind of have to be a little obsessive freak about each sport.
You got to be passionate about understanding load and positions. This kid plays a position that's like a slot receiver position. So the amount of cutting and change direction things he has to do is great. The good news is that he's offense, so for the most part, he's in control of his own body. Whereas if he was playing defense, that'd be much harder. This would be a much harder sell, much bigger challenge. But there's many variables. We had a kid earlier in the year that had a shoulder dislocation problem. And he plays a defender. He's a defensive player in the football. And it's like, well, unfortunately, it's week 3. Like, what are we going to do? You can keep dislocating it. You're a senior. And then there's other factors like, do you want to play your senior year or do you want to have surgery? You're going to have surgery either way if you want to play football again. You could keep going and keep dislocating it. We try to put a brace on it and try to stabilize it and do all the things. But the reality is, like, at the level you're playing at, it's probably not going to do anything since we're in the middle of the season and it's week 3. Like, it's just the outcome's not looking good. Although we could get away with it, right? But what's more important here, the psychological decision, the emotional decision, or the healthcare decision? And now these guys can fix so much stuff that maybe that's not the worst case scenario if he has a couple more dislocations, but he's able to play and has a fond memory of his final year.
Well, I think there's
on a meaningful team. This team is extremely good.
I've known amazing orthopedists in the space, and I've known not so amazing orthopedists. And I think sometimes you can be a great orthopedist and do great surgery, but really have a lack of care for the person in this moment. It's common to go to a decent, if not good, ortho and ask for their opinion, and they refuse to give it. They refuse to kind of offer any insight or recommendations. This is what I do. Your choice. You could take it or leave it. Where as a physical therapist, we're accepted a little bit more into the journey. We're more part of the journey with the person, and that means that they ask us, our opinion. And without necessarily saying you should definitely do surgery, or you should not do surgery, or you should stop the season, or you should continue with the season, I think it is up to us to ask the right questions and the smart questions and the investigative questions to see how important the sport is for their life. What's the future like? Are they going to continue on? Are they stopping this year? What are other goals to help them put this whole thing in context, which is a huge psychological investigation that you're doing, with the patient, with the athlete, with the family. And if you do this well, you become a trusted partner in their journey. If you stay detached and just give the facts and say good luck to you, you'll find yourself not really moving the needle, not moving the community or affecting the sport at large. And when you give that energy to the world, that means that you're kind of denying any entry into this journey of sports medicine. So we should welcome this pressure and welcome this stress.
I think that's a great point you were discussing there. I think part of one of the steps here, I don't know what step we're on, 4, 3, something of that nature. We haven't said the other 2, but nonetheless, they're in there. But I think having a network that you can reference the patient to is extremely important. And to your point there about having a strong orthopedist partner, a strong massage partner, a strong chiropractic partner, a strong athletic training partner, like it's really our responsibility to have that network around us. So when that call comes and you have options of what to do, it's like, all right, well, let's get to see this guy and do it quickly. Because it's not to say that you want like these certain special people, but you want people that know sports, who understand the concept of urgency. Mm-hmm. Like we need to make a decision now. The decision we make in the next 48 hours, the next 24 hours is going to be a critical decision, because then we're all going to go back to say like, okay, we made a decision to go ahead and play. So if we made a decision to play, then we have to manage that a certain way. If we make a decision to not play, then for how long are we not playing for is very, very important. What are we doing? Are we trying to do 1 week? Are we doing 3 weeks? Are we doing 6 weeks? Are we done with the season? Mm-hmm. Let's all get together and like, let's lock that down quickly. And then we can execute. So you have to have people in your network that understand sports, where to your point, you might have an athlete that gets feedback from a doc or from any provider, and they might say, oh, well, it's going to be 6 weeks, or, hey, yeah, you could do this or you could do that. It's your choice. Versus helping them understand, like, here's the risk, here's the potential benefits of continuing to play through it. Here's the reason why it's a tough decision, but this is the data. That we know most of the data. Like on a shoulder dislocation, we know what most of the data is. We know that there is risk to continue to play, although it's fairly well mitigated. And if playing is important to you, and it's going to leave a legacy as to like who you are and what how you become, that you're going to get through this difficult time, get your arm fixed, be fine. Mm-hmm. It's not going to have this like incredible like long-term disability problem. Whereas like if you tore your ACL and then you tried to play on that would be a different situation, right? That's not the same problem. It's a different problem. Yeah. Or you played on a spondy that was like unstable. I mean, there's certain things where you have to be, we're smart, we're strategic. Risk reward is everything. But like on an ankle sprain or like on a shoulder dislocation, it's like you can get through that as an athlete. And those are some times where you try to push it and get back in the mix. So.
Well, that definitely lends itself to those with some experience, either playing the sport themselves, being injured themselves, or really kind of managing a lot of athletes and seeing how that's managed well. Because mitigating that risk is not easy. It's not like you can ask ChatGPT this question. The LCL has mild laxity in Deverum. What's the likelihood of them re-injuring this Friday night football game? You're not going to ask AI anything like that. You're going to search through it in Google, and it's not going to help you. It is a little bit more of a feel. You have to capture how well the athlete manages it mentally. What are they like physically? Do they have all the attributes of great motor control, stability, and strength? Or do they have some underlying dysfunctions that probably led to the injury to begin with? So we have to answer all these little small buckets about the whole personhood and the environment they'll be playing in. Is it a mild level competition? Are they a little bit younger, a little more pliable, or is it fierce and best of the best in the area? So there's a lot to this to manage an athlete in an acute, subacute phase, especially in season, especially coming to the peak of season, where they will pressure you. They will ask you the tough questions. And if they don't like what you're selling, if they don't buy it, they just ignore and they'll go somewhere else and they'll ask someone else the same question until they find a response that fills their need.
Yeah, I think that's a great one. I think you really have to be able to talk. You have to be able to talk the talk and talk through it, and say, let them know, like, if we were to play through this or were to play next week and not miss any time, here's what the risks are, right? Mm-hmm. And then if we choose to take some time off, this amount of time would give us this opportunity, this amount of time would give us that opportunity, meaning like, hey, if we take 2 weeks off, maybe that's enough time to get the swelling down and get this thing to a fundamental level, but it's not going to be able to be amazing, or versus if we wait 4 weeks, we can kind of do a full rehab, we get the swelling down, we can get it back strong, and then we could probably get it to be able to bounce pretty good, and you'll be in a much better state. So I think being able to like talk through that with all parties involved, meaning the athlete or the player, the parents if they're involved, the coach, and then if there's a doctor or another provider involved, you got to be able to go to all parties and be like, all right, hey, these are the things, and then this is the athlete's decision based on this information. In some cases, there's no choice to be made. It's like clearly the bone's broken. Okay, we have to have surgery. We're done. But in a case where there's a little bit of a gray area, I think that's really, really important to be able to like lay it out there, because you're absolutely right. The worst thing you could do is say, "Oh no, you can't play."
Yeah.
And then hold that too tight.
Yeah.
To be like, who says you can't play?
Yeah.
I mean, if the kid walked in, he could go.
Yeah.
It's just, should he go is the next question.
Well, you lose credibility if you just kind of make a blanket statement and then the kid's like, oh, yeah, well, watch this. I could just do these things without any issue. They won't trust you.
No.
So you lose credibility if you kind of make that kind of statement.
Yeah, you don't get to be the godfather anymore. That's not the way the world works anymore. So like you said, ChatGPT's out there, Twitter's out there, Instagram's out there.
And coaches are better than they were 20 years ago. They're more astute. They understand the difference between pain and injury, and they'll call a shitty PT out. Like, hey, I think we can play through this.
Sure.
I don't believe you.
Yeah, you have to justify your cause. Yeah, you gotta be able to tell the story. You gotta be able to talk it out. If you can't talk it out, then, and if you try to play the godfather role, like, oh nope, you can't play, they'll find someone else that says okay.
Yeah,
that's how the world works nowadays. But if you lay it all out there and say, hey, these are the options. This is what I would do if I was you. This da da da. These are the odds. These are the percentages. Look at the literature. If you know that stuff well and you're ready to have that conversation, it goes very, very smooth. It becomes very obvious what the choice should be, and then we go. We either choose to go with the obvious choice, or we choose to go in a different direction, which is all right, if that's what we're gonna do, then it's not on me. I told you the risks, but let's tape that baby up and let's see what happens. I think that's a great arrangement. That reminds me of the movie Miracle, where the doc tells Coach, he goes, well, yeah, he can play him, but he's not going to be very effective. And Coach is like, well, let me determine that. I'll determine how effective he is. But a lot of times it's a good conversation with an athlete. It's like, yeah, you could stand out on the field, and yes, you can go through warm-ups, but can you really guard somebody and stop them, Or what is your role? If you're the tight end and you don't have to block, I mean, that's a pretty viable position. You can play at 80% or 70% and be effective if you're big, and you take up a lot of space, or if you're the DB and you have a little ankle sprain, it's not good.
Yep.
It's a tough situation, because
Yep.
speed and agility is your strength, right? And if that's taken from you, it's not so good. But if you're the tight end and you lose, you have an ankle sprain, it's like, let's wrap that baby up. Even if you only run 70%, you're still effective. You run short routes and you're bigger than everybody else,
Yeah, to get a little technical here, I think it's easy to see how a small injury can go sideways in a hurry and lead to a bigger injury. And it goes something like this. You have a mild injury that causes swelling response. The swelling response gives you a little bit of inhibition. And say you lose 10, 15% of strength locally in that area. And say it's a stabilizer, or maybe it's the brakes on the system, like a little bit of quad inhibition or some peroneal inhibition. And you won't know it. It won't immediately address itself. And then you start doing some functional activity. You squat, lunge, jump, run. Say, hey, the body works. I can do this. But your body will be compensating for that little bit of strength loss, because if you inhibit for, say, 4 or 5 days while you're swollen, the body does not immediately correct that strength deficit that's now 10, 15%. It just uses other things. That's the brilliant ability of survival. It doesn't care to expose the problem. It wants to compensate around the problem. And so now you're running routes, you're doing these things, you're being functional in your sport with this deficit, until one time you blast off at full speed, full power, except when you lack that stabilizing strength, you lack the reactivity. The reactive speed is like a magnifier. If you have a 10% deficit in strength in an area, it will be more of like a 20, 30% deficit under speed, which we measure as reactive strength. And that's, I think, the ultimate issue here is that 100% speed, game speed, magnifies a small problem, and it makes it into a very, very big problem. And now you have an increased threat of joint stress. Now you have an ankle sprain that leads itself to an ACL injury. Now we took something small, poorly managed, and you make something really, really big. And that is the worst thing. If that's ever happened to you, that should be a slap in the face that you weren't good enough for the community in that role.
Yeah, I agree. That's where it really goes south. That's where you have to really be clear about, the risks and expectations, and that's it. If you hurt a certain ankle joint, or a certain joint, that's not the joint that's going to get hurt next, most likely. If you tape it up and you work through it, it's going to be something else that you compromise that's going to go down. Unfortunately, we just saw a kid who had an ankle surgery last year, never did any kind of rehab for it, and we did the screening process, did the testing, and we looked at his jumps and his power production, and he had about a 20% asymmetry. And within 3 days of that, we were just reporting the data back to the coach. And I think that day in the afternoon, the kid tore his ACL on the same side. And then seeing the kid since then, we've seen that the dorsiflexion's limited. Clearly, there wasn't control there. He had lacked range of motion, which is one of the telltale key indicators. And then, obviously the force was transferred to your point, compensated.
So, going back to what sports medicine is, if we don't have rapid access and a rapid intervention in the journey, what happens is a lot of sports injuries, after 3 weeks, they feel better. So if you can't get an evaluation for 3 to 4 weeks out after a sport injury, the kid's going to feel better. They're going to say, I don't need to go to PT. I feel fine. I can run. And then what's the parent going to do? I can so see that you're dysfunctional when you do that liftoff. But we shouldn't be expecting parents to have this full understanding of how biomechanics work. And then the coach sees him run. It's well, I guess you're good to go. You have any pain? Nope. Let's rock and roll. And so these sport injuries, they go by the wayside purely because there's not this rapid access. And young people, they'll mitigate inflammation healing very well, but they will not address the dysfunction very well because they are human. They're young, which the vitality of the cell allows for things to heal, but you don't get rapid strength because that's not how the body works. It's built to compensate, not expose itself.
Yeah, totally agree. I think just on this note of this early access and decision-making process probably comes down to imaging or making sure that you got the whole picture. I think that's always a tricky thing, especially in our role. We can't order imaging and that's such. So this is, again, where you need really strong teammates and strong colleagues in the medical field as doctors and orthos, where you can say, hey, here's a situation. We've got a kid. This is somewhat urgent. He's got a chance to play. And we need kind of an urgent support here to see if he should be cleared to play or not. Does he have any kind of underlying thing we can't see? Is there some sort of a hairline fracture or something small? Is there a cartilage tear or some other damage we can't see below the obvious injury that's occurred? And getting that imagery can be, really critical in that decision-making process. I think if you notice the limb is swollen and the joint is swollen, there's an effusion, it would be irresponsible to say, yes, we can just play through this. So let's keep that in mind. But if that was what was presented in front of you and you're trying to make a timetable of return, having an image really, really quickly would give you the best ability to kind of create a good timetable. You shouldn't be trying to fight an effusion, which is likely a ligamentous injury or a cartilage injury. You really shouldn't be fighting that to say, hey, we're going to go back this week. That should probably be a couple weeks out. The question is, how bad is it?
Yep.
Is it a small tear? Is it a little bit of a fracture? Is it a contusion? What are we dealing with? Yeah. And we need the images to support us with that. So that's not always your call, but it's your job to weigh in on that, to have some influence, have some impact, understand the situation, and then work with your medical team to get to a good doctor that you can trust to say, hey, this guy's amazing. He'll get you in right away within 24 hours, go in there, get the imaging done, go see the doc. Now you got the doctor's opinion, you got an image, you got a PT opinion. Now you've got something to work with. Yep. So you want to tighten up that loop of your network so that you can serve the patient better, even if it's not you doing all of the service. You're still quarterbacking it and helping them facilitate through the process. So I think that's really important.
I think that's a huge opening in the field that wasn't necessarily there 20 years ago, maybe not 10 years ago, but to be the quarterback of the journey, to be a sports medicine director for a team, for a community, for a group, align yourself with a coach, align yourself with a club, align yourself with a school. I think more than ever, this is where PTs that are more sports-minded need to focus their efforts, is to be that alliance with those people and create the mini village. And I think the village can have a lot of different fingers out there, like you said, chiro, massage, orthopedists in different camps, in different systems, doctors in different systems, maybe have a few different types of medical people on your speed dial. And I think that's absolutely critical. It's a huge change of, rather than being a clinician that people call and get in line for an evaluation, that you engage, that you put an active role into the community in this way. And that's a very different flip than just, stepping into your little clinic, your little box every day, and whoever makes the phone call, that's who I help. It's flipping the whole story.
Well, this is what we've done at KIME. So this is the flipping of the script idea, is that we have the luxury in our field and as PTs where we get to go out and connect with the community and work with athletes and work with teams, work with coaches, and we get to know a lot of people. And as a result of that, we should be the first call and be really on the ground as to, hey, the athlete knows a guy, they know somebody, and that should be us. That should be one of our clinicians that's developed that relationship. They call that person, and that person can then facilitate it and get it back to the right doctors and help get it to the right colleagues to get the right decisions made. And it's a really fun way to practice, and it's a really good way to use direct access in that regard. I think this goes beyond just the athlete stuff as well. I have a client who's just messaging right now is looking at back pain, right? And there's a guy, who's an active guy, 65 though, he's a Medicare guy, but he's active, has a back problem, needs further help. We've been treating this for about a month, and we're not really making a huge headway. We've got the pain down and neutralized quite a bit, but it's still there. It's still very much there. And he's had some history of some trauma to it in the past, so there's probably something that's leading to this. He got some radicular symptoms down the leg. So even though we got neutralized, it's like, hey, we need the next step. So, trying to get him into the doc so he can get an MRI and then get to the next doc to consider, like, do we do something else, like an injection or a surgery on the table? It's been an amazing process, And without me facilitating him through the process, we'd be looking at, we'd gone through like a month, then we got the doctor's appointment, which was another, at first it was 6 weeks out. I got that moved to like only 10 days out, and then get that done. Then he wants an EMG and an MRI. That's another 4 weeks, So we got that bumped back up to about a week. And then it's like, okay, now I need to meet with the surgical specialist. Okay, well, that's 2 months out. Okay, let's get that back. And so we got to get these things down to like more functional time. And what's pushing me to do it is not just because he's some dude. Like, he's got an active drop foot. He's a really active guy. I know that if we've got nerve compression, we've got a problem. And we need to get that addressed quickly. So going into a 4-month holding pattern just to get the right information just it's just not best practice, right? So I'm trying to facilitate it in the form of best practices, like, hey, let's get this guy some help in an appropriate time. And he happens to be a coach of a large, very, very large team. So it's nice to be able to help those out that we've kind of, had in our network for a long period of time. But anyways, it happens. The more you can do that, I think, and that's an active role you play in the sports medicine space that you need to play. It's as if you were on a pro team. If you were the PT on the pro team and you saw the athlete, like, you'd be working with a lot of people around you to get the athlete the best care possible. And the same thing is available to people in a private market. You can do this, but you have to build a network around you of people that you can know, trust, and engage with, and you can facilitate, you can offset some of the time delays that usually occur in the private sector. And I think it's really important right now, especially when everybody around us is like 6 weeks out for an appointment. It's not that that's horrible, but the person's going to lose their whole season. It is horrible, actually. It's not. It's not great care because then everything changes. The person's fitness level changes, their activity level changes. One of the reasons why like pro guys have such good outcomes on surgery and return to sport so fast is the surgery happens within a week of the injury. So there's no atrophy. But if we have an athlete that goes, 6 weeks just to get an appointment, and then another 3 months to schedule a surgery, well, then we have 4 months of atrophy before we start the rehab process.
You're really climbing out of the hole at that point.
Now at that point, and then we can't strengthen them for several months because they're going through all the post-surgical work. So then, they're 6 months out of their last peak performance. Whereas like, an elite athlete like Brandon Ayuk we talked about a couple weeks ago, he goes down, he probably has surgery within 10 days. So he hasn't lost any muscle mass, he hasn't lost anything. Like, he's ready to go. And we don't have to recover from that. So it decreases your downtime significantly.
Well, we have a great network of orthopedists that we've built a lot of trust with, and I think that the massive value is being able to have just a good, solid 1v1 conversation with them about patients that need their help rapidly. And we have, I feel very blessed to have such great orthos that we can call at a moment's notice. And those doctors will say, we'll look at the case from our eyes and say, oh, this is a rapid case. Let's bring them up. Because the truth is, for a lot of orthos, they might have a lot on their like bucket list that's an elective procedure that whether or not it's 3 weeks from right now or 5 weeks from right now, it's uncomfortable for that patient, but it's not a dire consequence to the outcome or to that journey. But for a lot of these really traumatic injuries, Yeah, I guess you could say they are still elective. An ACL reconstruction you could say is elective, but man, it's a horrible journey if the whole thing is delayed, and tissue gets stiff, tissue gets atrophied, and we're dealing with a young person, so the trajectory of their life is really messed with when they're delayed by 6 or 8 weeks.
Yeah, especially on major ligament too, because it's as we've talked about, the recovery time is 9 to 12 months. So the faster that starts moving in the right direction, the better. Yeah, I think that we're really fortunate with the team of people we have that we can go to them and get the great stuff. Like doctors want this, doctors, same as a PT, they want to be with active, healthy patients. They want to work on an athlete. It's easy to operate on an athlete. Like all systems, you don't have the comorbidities, all systems are a go. So it's a much easier process for the most part. Mm-hmm. There's a lot higher threshold of quality. Like you have to do things very, very well, and the outcome is put under much more scrutiny. Than maybe be for someone who's not going out sprinting and running and changing direction at 100%. If someone's just going to go walk and hike, that's a different ACL than one that's going to play DB. So
yeah,
I think that all of that is weighed in, and you want to have surgical partners that want that challenge, that look forward to it, and say, yeah, this is what I do. Give me this opportunity.
Absolutely.
I think this is a good note on this same topic of. That was a lot of that was about direct access. I think it's a great win. I also think a lot of that's about education, about being educated and knowledgeable in this space and being able to execute at a high level. You need both of those, and you got to really work to get that education side up. But I was this thing that came from the APTA the other day. I got a survey that I'm not a member of the APTA, just to be clear, but I received a survey from as whatever, I guess, a licensed provider. I was impressed with their process. So we're going through the same process as a company right now, the corporate planning cycle of what are we going to do next year, what are our goals, those types of things. So the APTA happens to be doing it as well. So they sent me a survey to ask my opinion on things. I'm sure some of you got them. They probably went out to many people. And it asked, hey, these are our strategic objectives. How well do you think we hit them in the last year? And then informing their strategic objectives for next year. What feedback do I have, et cetera, et cetera. So it was an enlightening process because I'm not the biggest supporter of the APTA, mostly because I think I look at things in a big picture. And I think that if I look at our profession as physical therapists and the APTA being our governing body, I have to commend them for the fight that they fought at the end of the 90s and early 2000s, get direct access. Mm-hmm. And part of getting direct access means that if a patient wants to see a PT first, they can. Mm-hmm.
And their insurance pay for it, and it's within our scope.
That's not exactly clear. The insurance pay for part, unfortunately. This is where I think they failed. Mm-hmm. But direct access, yes. So the state legally gives you the right to go to the PT first and not have to go get a prescription from your doctor. Mm-hmm. And in almost every state that's viable. And some of them, they're more limited. Like in California, we could do it 12 visits or 45 days. In a state like Nevada, it's wide open, or in Arizona, it's wide open. Texas, it's wide open. They don't have any restrictions around it. Now, whether your insurance pays for it or not, they will deny it, although that would be illegal considering the situation. But the insurance would say, we have internal rules that require you to have a prescription from your doctor, which is fine. But anyways, the point here is to get the direct access. Part of that equation was to get the PT up to a doctorate level of education. Mm-hmm. So if the PT is a doctor, then they should be able to differential diagnose and they should be able to handle direct access with no problem. So fully commend them on this journey that they went on and they got it done. They pretty much got direct access and they got the doctorate degree. That's great. The problem is that they didn't get the insurance companies to buy in on this whole game. And as a result now of looking at the last 20 years, I think they've nearly destroyed the profession, right? Because now we have student loan debt at an all-time high in our field, where we have people getting $200,000 in loans for getting a job that pays just maybe over 6 figures barely. So that loan to income ratio is
brutal.
Yeah, it's not advisable.
Yeah, with interest rates.
Yeah, and then you're paying these people are paying 6 to 8% on a loan right now. Yeah. Like it's an insane amount of money, and it's going to be on them for 20 or 30 years. So that's really different than what it was. Like what it was in the early 2000s is you might get a loan for $50,000.
Right.
So the reason why that's a big deal is because they got the direct access, got the education right. Education has ramped up the cost dramatically over the last 10, 20 years.
Yeah, threefold.
Yeah, at least threefold. And then you have the insurance on the other side who has not increased pay at all.
At all, yeah.
Actually,
And demanded more work to get it.
Yes, exactly. Yeah, now we need more authorization, we need more paperwork, and then we need Medicare, for example, is every year talking about cutting the reimbursement, cutting the amount of pay, and putting more and more restrictions on your ability to get paid. So they're actually, the federal government's decreasing reimbursement, and at the same time, all of the state schools that provide physical therapy education are increasing cost.
Yeah.
So
it's a great combo.
It's a great continuum there that we've got. So, and I just feel like the APTA is not, they've never won the battle.
Yeah.
And I'm not even sure they're in the argument, which is my biggest problem with the situation, is that we got step one done and yahoo, hurrah, you just won something and now you just ruined it for everybody, because now people can't even become sports medicine physical therapists because they can't get paid enough to pay off their student debt.
Yep.
We've had multiple people that have wanted to work with us and join the group, and they just can't physically make enough money.
Yep.
This was years ago. We've transferred that now where I think we can get them in that position. But even still, it's a huge battle that we're facing in the industry.
Well, the company has to be, big enough to tackle the insurance beast, which has its own issues, and you need 3 or 4 different types of roles just to tackle it and get the money that you're owed. And it's but the other difficult thing is to be in sports medicine. There is a huge pull for any company, for a PT, to take insurance, because we're talking about sports medicine. We're usually talking about youth athletes between the ages of, say, 8, 9, 10, all the way through, early college. And when people get hurt, they're more likely to use their insurance because the parents have to pay a sizable amount just to take care of their family for, catastrophic reasons.
Yeah.
And so if a family is, burning $1,500 to $2,000 every month on healthcare, and they have an injury, they're likely to use their insurance because you just feel compelled to, because you already know that you're putting $25,000 a year into it, and so it's powerful pull.
Yes.
And so if you don't take insurance, it's very hard to say you're in sports medicine if you don't take your insurance. Not to say it can't be done, but very hard.
Yeah, absolutely. That's exactly right. A lot of people are like, I want to go cash pay only. That's great, but you're not going to see the sports people most likely. Maybe one visit, but you're not going to really see them be able to have the impact that you'd like to have. At least not the one that I'd like to have.
Well, because the other truth, to be good at sports medicine, you need a lot of reps. You need a fair amount of volume of different sports, different types of athletes, different size and shapes to kind of get the range you need to address the majority of different sports. To get that range, you're not in the cash pay model. You won't get that type of breadth of different types of patients in this space. And so the only way to get the experience is to really kind of be in the insurance model.
Yeah.
I've yet to see a only cash pay that's seen every type of athlete, every type of sport, and they're just humming, seeing patients every day. Usually those who are primarily cash based, they're a little more on the affluent side. They're usually a little bit older, and they can afford it. They can afford the regular care. If you're seeing athletes in a cash pay, it's usually like these 1 or 2 offs. You're not doing the ACL rehabs. You're not doing the severe fractures or severe ligament ruptures that are non-op, because that takes 7 months, 9 months. And that's really hard to do.
It's just hard to justify cost. But you can have huge impact on those people, but a lot of times you're used more as a consultant or do this for 2-3 weeks, then come back kind of a deal. But there's times in the rehab process where that's totally acceptable and fine. But the overall cost is quite high to the person who's already paying a premium for their insurance, and that continues to go up. We were on the sideline of a soccer game this Saturday, and that was the conversation. The mom's like, what do I even have insurance for? Like, what do I even pay for? Like, she's like, I have this like huge high deductible plan, and then I go to use it, nothing's covered, which is fine. I don't mind that because it's a high deductible plan, but then my premium keeps going up like $500 a year, and she's like, what are we doing? And it's like she's like, I'm wondering if we just go to like the self-insured model. I'm like, yeah. I said, well, that's fairly risky, but if you get something more like lethal, then like a cancer or something more dramatic, then you haven't seen a medical bill until you faced 10 days in the hospital and gotten some of the meds for that. Then that's a different medical bill altogether.
Yeah, you take a little predictable surgery, like an ACL might cost you 50, 70, 80
Yeah,
grand.
it's probably just under 100 grand.
But yeah, 700, $1 million from something really severe. Like, well,
Yeah, you can go 50 grand in the hospital just on a one night stay, so
yeah.
just the trip to the ER, I think, is up to 10,000. But back to the APTA thing, I think some of the things they asked about was what their focus should be and what it's been on, and they made a few comments and said, some of our focus has been on gaining members and some of our focus has been on educating the community. Choose PT first is one of their big initiatives. And I just have to say, I feel like as a federal agency, nonprofit that represents the therapist, that's just totally misguided use of the funds, which is one of the reasons I'm not a member, is that I don't need them trying to educate the community that a physical therapist is a good choice. That's my job as a private sector out here in the community. It's my job to educate the community if I'm anything good or not. It's not theirs. What good does that do? There's an infinite amount of money there that will never move that needle. You know what I mean? Yeah. And then if you're talking about gaining members, that's about value. It's not about marketing. Yeah. If you demonstrate good value, you'll get more members. Yeah. I would join in a heartbeat if you could tell me, hey, we're here to do two things. We are here to set a standard of education, to standardize the practice so that everyone has at least this level of education, which I think they do a good job of and they need to continue to do. And then we're going to go battle for you on regulation. Yep.
Because we can't do that individually.
I can't do it.
Even a small business.
Even a hospital can't do it.
Yeah.
Can't do it. They have to go battle. If they standardize education and go battle on regulatory issues, the office is 30 minutes from Washington, D.C. for a reason, I'm assuming.
Yeah, and standardizing education, I don't think is that big of a deal. It's not like it should take them 10,000 hours.
It hasn't changed.
The schools are the one educating people. They just need to make sure all the schools are in alignment with a box to be checked here.
Which is easy. It's hey, here's the national test. Make your kids pass it. Here's an example.
Yeah, just hold all the schools to some standard.
So they have their accreditation, and I think it seems to be a fine process. I'm sure everybody hates parts of that, but at least it's there.
They actually said their strategic objective is to gain members.
Yes.
Imagine spending money to a group of people and say, we're going to use those funds to get more people like you. What? Yeah. You're using my money to get my neighbor? Yeah. How backwards is this? How does that help me? That blows my mind. It's even said. That's so backwards in how they should be thinking. That amazes me. It's in there. I think that's actually just borderline stupid. I think it's right there. It's wow, that would be the definition.
Well, and then on top of that, I'm a little bit debatable about them having their specialized certifications. So they also put a tremendous amount of money into that. Culture was one of their other variables of focus points, was to improve the culture of the profession. That's not your responsibility. So that means conferences and giving them the PT as a pathway, become an OCS or an SCS or whatever. And those are all fine, but I almost wish that was owned by a different body. Yeah. Maybe they sponsored it, but an educational body that focused on actually high-level education development, monitored that, and was a branch of that.
I never voted for them to be that governing body of me. That's also why I've never given them a single dollar, because I have no respect whatsoever in them saying that. And that's when they're looking at a lack of people that are part of the APTA, that's called a vote. And people are voting, not you are in charge. And that's, unfortunately, should be a nice slap on their face. Change.
Yeah. Well, I tried to be pretty clear on my survey. So that was the two things that you should do, is regulate education, make sure that's a consistent standard, and then help us with the regulations that weighed down the profession that go against the values that you established in the early 2000s, which is direct access and doctorate degree. That's great. Now go support those to the insurance companies and to Medicare. If you get Medicare to do it, then the insurance companies follow, because every contract we have says, based on Medicare fee schedule. Mm-hmm. So get Medicare to stop threatening to reduce the fees, if there's value there. And if there isn't value there, then I have to go back and wonder, why did we fight so hard to increase the cost of education 20 years ago? Yep. Then that was a terrible mistake to suggest that we should go this route and increase the cost of education by over 3x with no potential outcome of improving reimbursement. Yeah. And they argued the same thing, that, you'll get paid more if you have your OCS. That's not true. Yeah. It's so far from the truth, it's ridiculous. Yeah. Because the insurance companies don't care if you have it or not. Yeah. They don't pay you anymore for having some sort of specialty certification. Versus if you look at how the medical system is set up, the AMA does not give the fellowship criteria.
Right.
If you want to be a fellow as like an orthopedic surgeon, you go to the American Academy of Orthopedic Surgery, and they have a fellowship criteria, and they have a specialty program that you can be through. So it's another entity that's a subsidiary,
a focused entity with a very precise mission.
Yeah.
We're going to do this
to be the masters of arthroscopy underneath the AMA.
Yeah.
It's a separate entity, but not for us. No, we have this conglomerate, which is the worst thing you could have in the world. You don't need a conglomerate. We need a single focus. Let's be sharp, be clear. And I think if you wanted to improve membership, that would be that'd be my argument for it, at least.
Oh, they're confused. Maybe you guided them in a better way.
We'll see. We'll see if they call. They said they might want to reach out. So that hasn't happened yet, but it's only been a few days. I'm sure it'll take, as a national entity, I will wait 45 days or so, and then I'll get a response. You know how we roll. I think if they were going to have like clear strategies, I think those are the main two things that we have to go after is keep education consistent, make sure the criteria is there. They do have something, they were asking about this. Should they spend a lot more time and money regulating education, like trying to decrease the cost? And as I think about that as a business person, I'm like, have you lost your mind? Like, you're talking about going to like, how many PT schools are there in the country? Like 60?
Yeah.
It's about going to 60 different entities and trying to get them to reduce their cost.
Yeah.
You know nothing about business. That's not how it works.
That's right. Let the market shake that out. It's always bad if an entity that knows nothing about business tries to control business.
It's ridiculous.
It's not good.
Plus to go to 60 different ones and get them to like, they're obviously charging a certain amount for a reason, meeting your criteria that you set. Like, if you want to do it, change your criteria. You can remove the doctorate degree, and then you're going to see the cost go back down.
Yeah.
You know what I mean?
Yeah.
So it's I just feel like they're trying to be in so many different places. And I think that just kind of led to so much confusion. And I think that the same thing's true in California with the CPTA is the governing body here in this state. And I guess their membership has improved, but I feel like it doesn't really serve us as like in the orthopedic sports population very much. It's tough because probably, I don't know if the number is maybe 80% of the therapists in California serve in a hospital setting. And don't serve in orthopedic sports science. So we're definitely a minority group, so I can appreciate that. But I'd love to see the funding go towards things that actually move the profession forward, like getting more, expanding the Practice Act, or at least like sustaining it.
Well, increasing the insurance reimbursement would be a monumental task because of all the components that you have to do that, really of substantiating care. And showing insurance that it's worthwhile and it's helpful and people live a healthier life with intervention. It is a big deal. Yeah. It's a monumental task. And if that was their single focused vision, I might give money to them.
Well, so that's a great concept. So that kind of was. Remember all this evidence-based practice? Mm-hmm. So that was them. That was these APTA and CPTA and all of them. That's evidence-based practice only. Mm-hmm. So then, all of this research is done. Mm-hmm. So-called research. They have 25 people in a study. Yeah. And the things that they studied were ultrasound. Yeah. Electrical stim. Yeah. Basic therapeutic exercise, EMG studies on muscle activity. Yeah. Well, what are the results of all that? Yeah. They don't really work. The results are they don't really change healing. They don't really reduce pain. They don't really improve functional outcome. Yeah. So then they've just given the insurance companies all the power in the world to be like, we're not going to pay you more because your services don't work. Because they're not studying movement. They're not studying better diagnostics.
They were studying something that's easy to study.
Yeah. And doesn't hold a lot of weight. And I think that would have been very quickly, I would have shifted gears there. But no, they pushed that agenda for 10 or 15 years on evidence-based practice, which I support evidence-based practice. Yeah.
It's so interesting because, within our company, the key research things that we bring to life are the evidence-based that if you can't get up and down off the floor, you effectively, you'll die within the next 5 years. If you don't have grip strength, that's at least 50% of your body weight, you're going to die in the next 5 years. Like there's very easy research that ties strength and movement to morbidity and how healthy you live. And they just got to zoom out. They got way too minutia of actually, looking at a modality and seeing if that helps. Yeah. You have to zoom out and look much, much bigger. And because we're humans, we're not rats. It's that simple.
Yeah.
So when you're studying a complex thing that has its own autonomy, and you cannot say, I need you to live life just like this during the course of the study because you're a rat, not a human. You can't do that. That means you need an insane amount of population to actually have any power in the study. Unless it's a simple, let's do ultrasound on this type of diagnosis. Oh, it doesn't work. Like, it's so...
1,000%. And I think the thought process here, if we've proven through evidence-based practice that ultrasound, for example, or the electrical stim is not the best practice, then let's get them taken off of the billing code sheet.
Yeah.
That Medicare is like, well, we'll pay you this for that thing, but we know it doesn't work. Well, let's just go remove it then.
Yeah.
And then because it's like 30 or 40 years old. Like it's an old technology.
Yeah.
That does it have some effect? Sure. Is it the best practice? Probably not.
Yeah.
And that's why we don't really use it. It's not best practice. We don't use it. We never build a code.
Yeah.
Get rid of that would be a great effort to be like, look, Medicare, we're going to get rid of a couple of these codes. We realize the evidence doesn't really back them, but it does back these things. Then that would change the profession because now you'd have people out there that are typically doing ultrasound because they get paid for it, not because it's best practice. They would stop all of a sudden.
Yeah. They'd also find that 38 minutes doesn't make any difference relative to 52 minutes. Like the time does not actually equal does someone get better or not. That's actually has to do with how the flow of business is. There'd be plenty of things that they would realize that how we're operating the industry right now makes no sense, at least in the orthopedic musculoskeletal realm.
Yeah, well, I think I would say it probably, from what I understand, even the hospital or skilled nursing realm as well. Like you're exactly right. Like a time-based code is horrible for the profession.
Yeah.
Because that means that it's only as good if I'm standing there staring at you, which is totally not the case at all. Like if I could be effective with a person in 10 or 15 minutes and teach them a few things, coach them, give them some tools, empower them to do the exercise, and then supervise them or give them a program. If I could do that in less than an hour, my value is probably, I would argue my value is 4 times what the hour time would have paid me. Because now that patient can go and maybe go for a couple of days or a couple of weeks without any other intervention, because now they're learning how to intervene for themselves, or they're learning better care.
But you can appreciate how the whole industry, though, is stacked. You know, for instance, if you were to obliterate time-based codes, you also then have to obliterate how they pay an HMO, and then, you know, the whole, like, well, then you could see 40 visits a day or 50 visits a day. If you could help 50 people from a physical therapy standpoint, more power to you. You are worth more. You should get paid more. But right now the system is built off of the HMO backbone, which means that you have a lot of fraudulent activity. People are forced to go into a certain provider. And so then you erase how the free market is supposed to work. If you don't have good care, you're supposed to say, I'm not going to go back there. That was pretty shitty. I'm going to go over here. But instead, the whole system forces you in these networks. And then that means like, hey, unless you want to pay $10 or you want to pay $100, you have to go here. Oh, so it's free if I go just to that one? Okay, I guess I'll go there. Yeah. So it's built on a system that I can see we've just kind of effed it up the higher up the system we get. So it's
this is what they should be focused on.
Yes.
This is exactly my point.
Yeah.
Is like I don't have the bandwidth or the leverage to go talk to an organization of that size to have any kind of impact, but they do, especially if all of us are with them and behind it. I would be 100% on board if this is what we're going to do, and this is worth some money to invest, and we're all doing it for very strategic, simple, focused attention. Nails. I'm all in.
Yep.
But this whole idea that we're doing all of these things, like taking the membership money and spreading the peanut butter like that is not going to be effective. No. You wouldn't do it in business. It's not how you run a business. No. You take the money and you invest. Boom, we're going to do this 1, 2, 3 things. That's it.
Yep.
You know.
Yep.
And you be strategic about it. So I hope that they get better. I'm not completely against them forever, but I do think that they should acknowledge as the APTA, and we should acknowledge as potential members or physical therapists that are licensed under this entity, that they've set up a path that's really been demolishing for the profession as a whole and been really, really difficult. And I think they're uniquely positioned to actually get out of that path and actually change some things. Yeah. So I hope that they can shift their attention to those types of areas, and I'd love to go to their conference if that's what we're going to talk about.
Yeah.
You know,
well, and also hold themselves accountable. This is our objective, and we did this. Then you'll have more people that'll purchase a subscription.
100%. Be clear about what we're doing.
Yeah. And if they fail, I'm taking the money back.
Yeah.
I'm not gonna pay another year if you fail at your objective, because that's how business works. That's how we all should be working.
Yeah. I'm confident if it was me running it, I would suggest that we drop the fee by like probably 75%.
Yeah.
So it's actually affordable to the therapists who don't have the money because there's so much in student loan debt they can't afford it.
Right.
So let's drop the fee down to a ridiculously low number, but let's 5x the membership.
Yep.
Where like if it's $200, I'd join. At $1,000, I'm not into it.
Right.
But if it's a couple $100 and everybody can do that, well, now there's like thousands of us. Now it's strong.
Yep.
You know,
Yep.
like the AMA. I think the AMA membership is like insanely strong, and the APTA membership is like less than 20%.
Yeah.
And therein lie is the truth.
Yeah, and I'm sure the people who are in it, their work pays for it, and the work just might be a big, huge system.
Oh, for sure.
That's,
And it's also it's the educators.
Yeah.
You know, I mean, I would argue that I bet 50% membership is education. Because when you go to the conference, that's who's there. You know, it's all the professors at the schools, the educators and stuff, which is great. You know, and it's great to have them, and it's a huge part of the profession. It's very important. But if they want to serve the licensed professional, I think they're missing a large niche of the population.
Yeah, they have to be of value.
But I also anticipate they won't serve our specialty niche very, very well. But I still think if we just speak for orthopedics in general, it's a pretty large
Which
subsector.
insurance reimbursement would do that?
Yeah, absolutely. And there's some changes they can make that, because no one in the hospital is using ultrasound or electrical stim or anything like that. So just get rid of this stuff. Like, let's go to Medicare with like a renegotiation contract of like, hey, let's get rid of these things that don't work anymore.
Yeah.
And let's move the focus onto these areas. But let's get a couple more dollars per code.
Yeah.
And we'll make this whole thing a little simpler and a little bit better.
Yeah.
I'm not in charge, but at any rate, good. So I hope them for the best, and maybe we'll get a chance to talk to them in the future. So, if you are a member of the APTA, I strongly encourage you to communicate with them, give them feedback, get them to work for you in a positive way, so that you can get the benefit of the membership. Nothing against it, but I'd like to see them do a little more focused attention on those things. All right, thanks for listening to KIMEcast. You guys have a great day. We'll catch you next time.